In Part 1, you learned the words. Now put them to work. 6 real-style patient presentations. Pause after each one and try to name the clinical term and the discriminating question before the reveal. Case 1. Patient says, "Doctor, I feel dizzy. It's not spinning, it's more like everything goes gray for a second, especially when I stand up." Pause. What's the clinical term? What would you ask next? Presyncope. The patient describes the sensation right before fainting. No spinning, no nystagmus. This points to reduced blood flow to the brain, not an inner ear or brainstem problem. Discriminating question: does it happen when you stand up quickly? Case 2. Patient says, "About an hour ago, my right arm just went weak, out of nowhere. My leg on that side too. I can still feel my left side fine." Pause. What's the clinical term? What would you ask next? Red flag. Unilateral sudden weakness equals medical emergency until proven otherwise. One side of the body, sudden onset. This is the classic pattern that must be treated as a possible stroke until proven otherwise. Contrast this with bilateral gradual weakness, which usually points to a peripheral nerve problem. Discriminating question: is it on one side of your body or both, and did it come on suddenly or gradually? Case 3. Family says, "He blacked out for maybe 1 minute. When he woke up, he bit his tongue and he was really confused for about 10 minutes afterwards, didn't know where he was." Pause. What's the clinical term? What would you ask next? Seizure, not simple syncope. Tongue bitting plus postictal confusion, grogginess, and disorientation after the event strongly points to a seizure. Simple syncope resolves in seconds with a clear, quick recovery. Discriminating question: how did you feel afterwards? Back to normal right away or confused for a while? Case 4. Family says, "My mom has been forgetting where she is since this morning. Yesterday she was completely fine. It's like it just came on." Pause. What's the clinical term? What would you ask next? Delirium, not dementia. Sudden onset over hours. That timeline is the key. Delirium develops acutely and often fluctuates through the day. Dementia is chronic and progressive, developing over months to years. Discriminating question: is this a new change or has it been getting worse gradually over time? Case 5. Patient says, "My hand shakes when it's just resting in my lap, but when I go to pick up my coffee cup, it actually settles down." Pause. What's the clinical term? What would you ask next? Resting tremor. Shaking present at rest, improving with purposeful movement. Classically associated with Parkinson's disease. Contrast this with an intention tremor, which gets worse as the patient reaches for something. Discriminating question: does the shaking happen when your hand is resting or only when you're trying to do something? Case 6. Family says, "His face looks uneven on one side, his speech is slurred, and when I asked him to raise both arms, his right one just drifted down." Pause. What's the clinical term? What would you ask next? Fast positive. Face, arms, speech, time. All 3 fast signs present. The next question is the one that decides everything. The most important question now is, when was the patient last seen well? This defines the entire treatment window. Quick-fire term check. Write definitions in the comments. Presyncope, unilateral sudden weakness, red flag. Seizure versus syncope, postictal confusion. Delirium versus dementia. Resting versus intention tremor, fast. Comment Neuro 2 below and I'll send you the free printable case drill answer key. All 6 cases plus 4 bonus cases not in this video. Follow for more medical English.